Hi, good morning. This is Dr. Arundhati Pandey. I'm working as a head of department and professor at now Symbiosis Medical College, Pune. I'll be talking about lead surgery, which surgery and why. So I'll be covering entropion, ectropion and retraction of lead. Entropion, everyone knows the definitions. I'm just going through slightly fast because of the time constraint. So what are the types of entropion? Congenital, spastic, involutional, cicatricial, and most common upper lid cicatricial, lower lid involutional. So factors causing involutional entropion, they are laxity of lower lid retractors, horizontal lid laxity, overriding preseptal orbicularis muscle. So what are the procedure, what are the options available? So vertical skin muscle shortening, that is a Ziegler cautery. Horizontal tightening of lead at lower tarsal border, that is big procedure or Fox procedure. Barricading of orbicularis fibers, that is Weiss procedure and Jones procedure. Tightening of orbicularis fibers, that is Wheeler's procedure. Reattachment of inferior retractors, that is Jones procedure. So I'll be discussing few cases. So we had a 60-year-old male with a lower lid entropion, and Weiss technique is done in this patient. So what is the principle? Transverse blepharotomy with marginal rotation. Transverse lid split prevents upward movement of preseptal orbicularis. Everting sutures shorten the retractors. So what I did is, after the preparation of the patient, subciliary incision is made, identify the lower lid retractors, dissect the retractors of the conjunctiva, advance the lower lid retractors onto the tarsus, everting sutures and closing the skin with the vicryl suture. This is the day 1. So he had a hematoma with mild ectropion, but with the gradual progression, you can see on the in the fourth week, there was a complete improvement. Then in this patient also I did Weiss technique. So this is a 70-year-old with a lower lid entropion. Okay, post-operatively there was a good correction actually. And this 70-year male, he had a right mild involutional entropion. Left eye operated 2 years back. So left eye had no problem. And again, okay, in this procedure, Jones procedure has done. So what is the Jones procedure? It is plication of inferior retractors, shortening of retractors to create a barrier to upward movement of preseptal orbicularis. So what is done? After preparation of patient, horizontal lid incision, it is deepened through the muscle, that is orbicularis. Conjunctiva is not open. Lower lid retractors identified. So ask the patient to look up and you can feel the tuck. And retractors are sutures to the tarsus. And so what I did is skin, lid margin, tarsus, lower lid retractors and the skin I sutured together. Okay. So Jones procedure in this patient, right eye you can see, and eventually see within the 1 or 2 weeks after the once the hematoma resolves, you will see a good results. And lid is really forgiving in this manner. So this lady presented, 50-year-old lady. She had right eye involutional entropion, and I corrected it with the Jones procedure. Now, cicatricial entropion, it is caused by shortening of posterior lamella, which pulls the eyelid margin inward. So what are the causes? Trachoma, OCP, ocular cicatricial pemphigoid, chemical burns, surgical or accidental trauma, Stevenson-Johnson syndrome, recurrent chalasia or blepharitis. So this patient, he had a right eye cicatricial entropion with eyelashes rubbing to the cornea and associated with the corneal opacity because he had around 1 to 2 years. So marginal rotation of the tarsal plate, principal lamella, and preparation of the patient after eversion of eyelid, incise the conjunctiva, upper border of the tarsal plate, separate the muscle, suture, cut margin of the tarsal plate to the skin with knot of the skin inside. Posterior lamella is preferred than the bilamellar tarsal rotation. So sorry for the these pictures, but he had a good improvement within 1 or 2 weeks. So upper lid entropion, 46-year female, she had a bilateral mild upper lid entropion, trichosis, dry eyes, and most probably due to trachoma. So what is done is a tarsal wedge resection, anterior lamellar reposition and lid margin split combined with the excision of wedge of a tarsal plate. And horizontal lead incision has been taken, tarsal plate exposed with a blunt incision, 2 incisions at 90° to each other made. So wedge of the, it is removed. Yeah. So electrolysis epilation has done and added with the platelet-rich plasma therapy. This was the ectropion. And retraction of the lid, this patient, 30 seconds ma'am, sorry. So retraction of the upper eyelid, so Muller's muscles, Muller's muscle was, mullerectomy has been done in this patient, and day 1 patient had a ptosis, but eventually patient recovered. Okay, thank you so much.
नेक्स्ट पर्सन जो यहाँ पे आएगा उसको भी रेडी कर देंगे.
As far as your lid retraction patients were concerned, were they the thyroid patients? So after it is generally seen, have you tried LPS recession also for lid retraction? So what results are you getting? Lid retraction doesn't cure so easily. You have to keep traction for at least 6 weeks. If you think immediate post-op, it definitely goes down due to the edema. But soon, if you do not maintain the retraction for at least 4 to 6 weeks, after 1 week, you will again find it going up. So you cannot just be very casual about it. You've done a mullerectomy and it goes away. I don't think so. I don't know. I do LPS recession and I have done number of patients, and we have to maintain a very good follow-up for that. You cannot just operate, send him because he's having a ptosis, now it's okay, and you just, okay. Mullerectomy, I don't think, okay. You want to present first? Yes, Dr. Saab, ek baar inko kare. Yes, Dr. Salil Kumar, yes, you were not there, that's why.
No, he can come to this side. He has already
मैम इतनी
started
जल्दी से
now.
खड़ा करके क्यों रख रहे हो? पनिशमेंट थोड़ी है.
हो गया तो खत्म. एक इसका हो जाएगा, then we'll do.
He has some presentation somewhere else. He's कहाँ पर है?
चलिए, नहीं ये है ना.
अच्छा.
Good morning all. I will be presenting a case series of multi-stage oral mucosal grafting for reconstruction of severely contracted ocular socket. So as you know, when we face the world, it is your face which comes forth, and in these present days of selfies and social media, your facial appearance is most important. So if the person who has developed oculoplastic requirement and he has a contracted socket, it requires a optimal cosmetic improvement. So socket contracture can be by various causes, as you all know. Even the repeated socket surgeries to correct the socket contracture can also lead to further contracture. So basically, you have to give the cosmetic enhancement to the patient by giving the properly fitting ocular prosthesis. Many surgical options are available when the patient comes, and if you see the literature, when you go for that severely contracted socket, let's say grade 4 and above, or grade 3 and above, the literature will describe dermis fat graft as one of the option for the contracted socket. But though DFG has been extensively studied, harvesting DFG and harvesting requires surgical skills, and it is very difficult to master. However, the mucous membrane grafting is what many of the general ophthalmologists also can be doing in their practice, because even the oculoplastic surgery, even the fellows, they are tuned to get a graft, including full thickness graft. So this study was aimed to find the feasibility of using MMG only for the repair of severe contracted socket. So these were the inclusion and exclusion criteria, and the contracture was as per the Gopal Krishna criteria, and grade 3 and above were contracted as taken as a severe contracture. Comprehensive evaluation including inferior fornix depth was taken. These were the few cases. You can see there are grade 3, grade 4, even a case of blast injuries and severely contracted socket, grade 5, where is a malignant socket. So all surgeries were performed under the GA, and mucous membrane graft was harvested from the lower lip after adding the additional 25% area in the defect. And this was transferred, and then a snugly fitted temporary conformer was given. These are the surgical steps for this procedure. As you can see, after this graft was well taken up, inferior fornix was formed. This is the stage 2 procedure, and the conformer is there in place. So what was done in this study? So when you grade 3, grade 4 or grade 5 contracted socket, we are giving the first mucous membrane grafting, we are re-evaluating the socket again after 6 weeks. At this stage, adequacy of the fornix to hold the conformer, donor side reepithelium was assessed. Repeat surgery was planned after 8 weeks post-op. And the same surgical steps were repeated, and the MMG was also harvested from the same site of lower lip mucosa. So what are the results? As we had taken this, since it was a cross-sectional, it was not a, it was a basically a non-comparable study. We had taken 7 patients, 4 were females, 3 were males. Two patients had sustained blast injuries, and 2 patients had enucleation done with implants. Grade 4, where the maximum number of cases were of grade 4, that is total number of 5 patients were in grade 4, 1 patient was of grade 3, and 1 patient was of grade 5. These are the characteristics of the patient, and number of socket level, this is the socket contraction, and the number of MMG stages required. So we had given 3 stages of mucous membrane grafting from the same site, harvesting of the mucous membrane grafting. What were the maximum dimensions of the MMG which was to be harvested? The average horizontal diameter was 28, vertical was 15, mean fornix depth preoperatively was and post-op 8 weeks was 2.9 millimeter average and 6.2 millimeter average. So it was statistically significant increase in mean fornix depth. Customized prosthesis we were able to give to 6 patients after giving the multiple stage of MMG. Donor site from which we had harvested the mucosa repeatedly, that is the lower lip mucosa, there was no complications. There is not, once you harvest the mucosa, if you have to take it properly without causing the damage to the lip muscles, so that it regrows and you can take the mucosa again from the same site, which is easy to harvest, rather than going for the buccal mucosa or going for the other stage. So if you see the discussion, if you see the studies, many studies will be there for grade 4 and grade 5 with DFG. There was one study which showed 658 DFGs were compared. But I don't think anyone gets so many cases of DFG, and even there are taboo for the patients also to give the to give the consent for the DFG to harvest from the buttock. So what we are saying is multi-stage surgery with the reassessment of the residual contracture, and not trying to achieve the results in one go, but repeated planning, and will be able to give a good fornix depth and good cosmetic appearance to the patient. Thanks.
Did you keep any fixed interval between your
8 weeks.
8 weeks, from
After
first to
6
second, second to
Second
third?
to third.
8 week minimum.
Minimum.
8 weeks.
Professor Solly Mandol. Next
But you are
presenter.
repeating the surgery again and again. You are giving general anesthesia to the patient. So why so many surgeries? We can go with other modalities of management.
That's what we are comparing. When the other modalities, when we say for grade 4 or grade 5, it only comes forth is DFG, which is poor. But how many surgeons, even the oculoplasty surgeons, are able to get the DFG? And if the DFG fails or there is an extrusion, then you are in a fix what to do next. So in this case, basically, after to achieve or give the cosmetic processes, you have to have a good fornixal depth, and that can be achieved with mucous membrane grafting. Mucous membrane grafting everybody is doing. Even that fellows we are also giving to them. So which is easy to the surgical technique.
You've been doing it under GA every time?
I have done most of the cases under GA. Few cases I have done under local. Basically, when you try to get the fornix depth and surgical grade 4 or grade 5, you try to make the scar tissue release under local, it becomes very difficult.
How about the
Thank
donor site? Donor site,
Donor side complications, there were none.
because you have taken multiple times, no? To
Yes, sir, there was none. And
Not possible that there would be none.
no, when you see after 6 to 8 weeks, you find that mucosa is slightly paler. There is a whitish. Even if you feel there is a band, but once you put the ignocane and infiltrate,
request all the speaker to stick to time actually, because this is a competitive paper. So if you are surpassing your time, then you will not be valid for the markings. Thank you.
Start.
Respected chairperson and my judges here, the topic is outcome of upper and lower lid retraction correction by novel FKPP in Graves' orbitopathy. No financial interest. In thyroid disease, second most target is orbit. Chronic inflammatory disease, autoimmune origin, females are most commonly infected. TAO, 77% are affected, 3% hypothyroid, euthyroid, and lid retraction mostly commonly finding. In early stage, this is retraction corrected by overactivity of the sympathetic overactivity, and the latter stage is fibrosis. The condition may be vision obscured due to exposure keratopathy and hamper the quality of life. So, to evaluate the study, to aim of the study, to evaluate the functional cosmetic outcome of upper lower lid retraction using novel filamentous knitted polyester fabric as a spacer material to appraise the safety, efficacy, and durability of the filamentous knitted polyester fabric. So, inclusion criteria, all the patients with thyroid eye disease having upper or lower lid retraction, minimum sclera, so 2 mm, limited proptosis, less than 2 mm retraction due to any cause, euthyroid. Exclusion criteria, huge proptosis, more than 20 mm, significant squint, restriction of ocular movement, TED, thyroid malignancy, skin disorder like Stevens and any infection of the skin. So, evaluation parameter, pre and post-operative photographs, pre and post-operative LPS action, pre-operative MRD1, MRD2 value evaluation, palpebral fissure height, pre and post-operative eyelid closure, patient satisfaction. In upper lid, the shape of the spacer material, 26 to 28 meter length, central wide depends upon the moderate ptosis, that is induced moderate ptosis, that is limbus to distance is 5 mm, amount of sclera also added plus extra 3 mm. This is the formula we use. And in the lower lid is 20 to 20 meters central wide, 6 meters central wide, which is fixed and rounded border. So the parameter, pre-operative proportion, MRD1 value 6.212 with standard deviation of 4.1, MRD2 value 7 standard deviation with 4.57, PFH values 14 standard deviation of 10.03 with standard deviation. Pre-operative LPS action is 18.42 to 12.92. Pre-operative mean scleration upper lid is 2.82 to post-operative almost nil, and the pre-operative scleration in the lower lid is almost pre-operative 3.1 to post-operative this is almost nil. So comes to the video. This is the lid retraction. Now, what is seen, the upper lid crease incision made. We detach the central LPS muscle and Muller's muscle, partly dissection, partly recession, and thrown back distally. And the new novel filamentous knitted polyester fabric used as a spacer material to hold the LPS for reattachment of the LPS to the tarsal plate. In the lower lid conjunctival approach, we detach the inferior retractor from the tarsal plate and create a semilunar space where the filamentous knitted polyester fabric as a spacer material and the conjunctiva deposited all over the tarsal plate and kept for 3 days. Reverse. This is the beneficiary of the patient in our study. So various spacer material use autogenous facilitator, bank sclera, orbital septum. This is not satisfactory. 1919, Courtney first used the 93% success rate with full thickness blepharotomy. Hutchison and Hurlix, they are doing a 95% success rate. Mulsits and spasm is a 32% success rate. In our study, we did 94.7% success rate. What enable 8 turnover orbital septum, their success is 80%. So use of spacer material orbital septum lengthening the levator appendicis muscle may not be possible in all the patient. In our study, FKP is applicable in all the patient. The formula used in Lee et al. Suggests that spacer metal distance dimension 2 into degree of restriction plus 2 mm. We use the formula, what is that? 5 mm. We use moderate tonosis, 5 mm, amount of sclera plus 3 mm extra. That is the central width of the spacer material. And we did a multiple hole over the spacer material. So novel FKP spacer material causes not only the lengthening of lead, it also prevents the reattachment of LPS and inferior to the tarsal plate. We use the 80-proline suture, interlocking suture, create a multiple hole FKPP. That's improvement the lead. And bank sclera had a disadvantage. Orbital septum does not vascularize, but Result is confirmed. The muscle in space also destroying very not satisfactory. So consequently, FKP is a good question and friendly material. It is not total exclusion, no. Thickness is 6 millimeter. Fabric is useful. Thank you.
What is your follow-up period?
Follow-up period is 6 months.
They are maintaining.
Yeah, but study is not yet complete. We have just studied, 8 months gone. The result is excellent. And still we are improving our series.
So how are you procuring this?
No, this is hospital supply. Actually, this material used in cardiothoracic surgery.
Okay.
This is a material which used for ventricular septal defect repair.
Okay.
Then when I see that material is used in cardiothoracic, why not is not used in eye? This is the material is flexible. All direction can be flexed and durability is much higher. So, and multiple hole, when you create it, the fixation is good.
And what
And
about the cost?
cost, madam, it is 3,000, but we did 10 inch by 10 inch square.
So you can use
and
it.
if you 1 inch, then effective cost is 340 rupees per patient. But our hospital it is almost free.
So how are you measuring the, you said, but I couldn't understand,
Yeah.
amount of,
The measurement is for the upper lid, it is 27 to 28 millimeter. And the central wide that we make a formula, induced ptosis, moderate ptosis, that is 5 millimeter.
Okay.
Amount of sclerosis which is measured, then extra 3 millimeter
added to it?
added. The formula used by the other scientists, they are into scleral show plus 2 millimeter extra. But we have used this formula, its result is good.
Okay. It's a good thing. Can try, but.
Thank you very
Next
much.
presenter. Next.
So next presenter is Anvesha Maitra.
Anisha Moitra
Doctor.
is there?
Anvesha, not there. So we come to next.
Next one को भी बुला लीजिए.
Aditi Mehta.
Aditi. नहीं ठीक है. You be there. You be here. No. ये तो Anisha is. She will.
You are Anvesha, please come.
She will.
And you can sit.
नहीं वो.
मैम यहीं बैठे हैं,
बस
इधर
ठीक है,
फ्रंट
ठीक है।
सीट में और
वही,
इसमें
वही।
कितना फर्क है, खड़े करके क्या
वो
करना
पीछे से ना मुश्किल.
हाँ, कोई नहीं, 1 मिनट का रास्ता है, कितना बड़ा हॉल है. Yes, please start.
So good morning respected judges and my dear colleagues. I'll be presenting on the viability of full thickness skin grafts with cicatricial ectropion of the upper and lower eyelid in acid burns. I am Dr. Anisha Moitra and I am from the Regional Institute of Ophthalmology, Kolkata. So in this study we explored the effectiveness of full thickness free skin grafts for correcting cicatricial ectropions in eyelids damaged by burns. Cicatricial ectropion can lead to severe complications which if they are not addressed can lead to severe complications, and hence it requires identification of effective treatments. Now results from malposition or deformation of eyelids following severe facial burns leads to eyelid malfunction and exposure keratopathy. This not only threatens vision by causing corneal damage, but also significantly impacts the cosmetic appearance of the eyelid. Our primary aim was to assess the viability of full thickness free skin grafts in the correction of upper eyelid cicatricial ectropion resulting from acid burns. This was a retrospective study of 10 patients treated over 2 years for eyelid cicatricial ectropion using full thickness skin grafts and tarsorrhaphy, followed by tarsorrhaphy. The inclusion criteria included patients with acid burned faces showing upper or lower lid cicatricial ectropion, and those with some visual capability, that is vision is greater than 660 and good Bell's phenomena. And exclusion criteria were cases with severe cicatrization preventing lid closure or entire corneal exposure keratitis. Now all patients received 3 doses of injection triamcinolone and 5-fluorouracil pre-surgery to prepare the tissue, and surgery involved creating an elliptical defect, removal of scar tissue and placement of a full thickness graft from the retroauricular area. This is the video of a patient, one of our patients with severe bilateral upper eyelid cicatricial ectropion. Now, so this patient, we first excise the scar tissue, and then we harvested a skin graft from the retroauricular area and then resutured it to the recipient bed, For this patient, a repeat surgery was required, for which we again harvested skin from the inner aspect of the arm, and the fat from the skin was excised and was again resutured at a later date onto the same area. So this is the procedure, and this is how we have sutured it onto the recipient bed. And this we have placed a tamponade after the surgery so that the graft fixates well on the recipient bed. And then we have done a tarsorrhaphy to splint the eyelid. So these are the list of patients that we had performed this procedure on. As we can see that there has been a significant improvement in the MRD, especially in patients with upper eyelid ectropions. There was 100% graft viability was achieved in all cases, indicating a high success rate of this technique. And minimal complications were noted, such as mild contraction in 4 patients and graft hypertrophy requiring revision surgery in 2 patients. There was significant improvement in the cosmetic outcome, improving both lid functionality and appearance. Success was attributed to rich periocular blood supply and meticulous surgical technique. Graft hypertrophy and contracture were challenges but could be managed with additional repeat surgeries like I just showed. And substantial improvement in eyelid function and cosmetic appearance was achieved, enhancing the patient's quality of life. Full thickness free skin grafts have proven to be a viable and effective option for treating upper eyelid cicatricial ectropion resulting from burns. Despite the potential need for revision surgery due to graft hypertrophy, the technique offers significant functional and cosmetic benefits. Further research is encouraged to enhance grafting techniques and reduce complication rates, and we obviously need to include more patients in the surgery in order to reach a statistical result. We extend our deepest gratitude to patients and medical team for the participation in education. Thank you. These are some of my references.
Thank you, Anisha. I have 2 questions. One is, in this type of cases, usually the post-auricular area is also involved. Means you cannot take the graft from that area.
So,
and in that case, what is your plan?
So ma'am, in cases where the post-auricular area was involved, we have usually taken grafts from the upper aspect of upper inner arm, and also from the abdominal area, lower lateral abdominal area.
And what are the complications you came across? Because the post-op period is not that smooth usually.
We observed
but you have not shown any of the complications. You said 100%.
Ma'am, the graft uptake was 100%, but obviously during the course of 6 months, there has been cases of graft hypertrophy, which has gradually resolved over time. But the major complication, or rather I would say the repeat procedure that was required in some of the patients was a repeat graft surgery was required because of the nature of the injury. There was repeated contracture.
That you should include also, no? What are the complications?
Why don't you use the supraclavicular area? That's more easier to use. Why going to the abdomen and going there? You've never tried supraclavicular?
We have explored it, yes, but then...
And the other thing, you are putting so much stress on the skin graft. I think the key role in your study and any other study is on the 5-FU injection. If you do this study in patients without giving 5-FU injection, the failure rate will be drastically increased because band effect and the retraction effect increases too much. So 5-FU you haven't stressed much, but the major role is by 5-FU and TCA injection that you are giving. The band and the fibrotic area, it gets very softened, and that is what helps in the success, increasing the success rate of the graft. So that is very important. What interval are you keeping between 2 injections?
3 weeks.
3 weeks. So minimum 2 weeks and then go to 4 weeks also. Yeah. Okay, thank you.
Thank you, ma'am.
Next we have Dr. Aditi Grewal, and she's going to speak on frontalis advancement flap. Can this procedure replace frontalis sling? Yes, it is.
Good morning, everyone. There are no financial disclosures. So we all know that surgical repair of severe congenital ptosis are often challenging, as levator strengthening is not sufficient, and we have to utilize the frontalis muscle. Conventionally, using the fascia lata or silicone sling, we bypass the LPS and suspend the frontalis onto the tarsus. However, of late, a technique has gained more traction, and that is the frontalis muscle advancement flap, which is directly sutured to the tarsus with or without a levator pulley. So if we look at the background, sling has been described first in 1880, and it is quite popular. It's a workhorse procedure. However, there's a risk of infection, granuloma, and recurrence of ptosis. And there's an inherent static nature due to the nature of the material, whether it's fascia lata or silicone. This produces a lid lag in downgaze and significant lag of thalamus. In addition, children may require multiple procedures over their lifetime as they outgrow. The frontalis flap is not actually new. It's been described since 1900s, where Fergus anecdotally described this incision using an eyebrow approach. However, this technique is not standardized, and off late in the past decade, because of popularity in the Asian population, it's been regaining traction. So we designed a study to evaluate whether this is going to be effective, what is its efficacy, how does it compare with the conventional silicone sling, and what are the complications with this technique. This is a non-randomized prospective study with treatment-naive patients of severe congenital ptosis, which was uncomplicated. They were either underwent the silicone sling using the Oculolab sling or the frontalis muscle advancement flap. The recruitment period was from July to January 2023, and the follow-up was minimum of 6 months. Baseline MRD1 amount of ptosis was noted, and the final outcome comparison was MRD1, lid lag, lag of thalamus, complications, and subjective response. So for the sling, we used the Fox pentagon technique with an Oculolab sling. And for the frontalis muscle advancement flap, I have a diagrammatic representation. So we use a central and a lateral suture to advance the frontalis muscle onto the tarsus. We went through, and this is a short surgical video, we went through the eyelid crease incision, after which the frontalis muscle was isolated by dissecting in the suborbicularis plane bluntly. The dissection was done with the help of artery forceps, and the frontalis muscle was not separated from the lateral attachments. It was just advanced forward. The puckering from the skin was removed again with blunt dissection. Once the frontalis flap was identified, it was checked by tugging it and seeing the movement on the forehead. This was then advanced and sutured onto the tarsus by incorporating a subvitrinal bite of the levator muscle, thus effectively producing a combined levator plication as well. Only 2 sutures, central and lateral, were applied. The lateral was higher than the central suture, and then the lid crease was closed with crease-forming sutures. So coming to the results, the baseline characteristics were comparable with an MRD comparable, although the silicone sling had a greater amount of ptosis as compared to the flap group. At 1 month, the sling seemed to be doing better, but at 6 months, the MRD1 was comparable in both the groups. Lid lag was present in all patients in the sling, but only in 87% in the flap, as well as the amount of lag of thalamus was much less in the frontalis flap group, although this was not statistically significant. So if we look at this, the MRD improves in both the groups, and at 6 months is comparable. In addition, the first panel is a silicone sling, where we can see a good cosmetic outcome. Also in the frontalis flap done in the right eye, at 6 months, the outcome is quite successful. The lid lag was there in all cases in the sling group, as well as in the frontalis flap, it was there only in 87%, and it was mostly mild or moderate. Coming to lag of thalamus, in some patients in the frontalis flap, there was actually no lag of thalamus at 6 months, which was an important finding. There was additionally a finding of recruitment of frontalis. So this patient underwent a frontalis flap, and when he's looking straight, the MRD looks a little low, but when he's able to raise his eyebrow and then see, the MRD becomes comparable, thus indicating that the procedure in itself is quite dynamic in nature. So coming to the discussion, frontalis flap has been compared with LPS resection in different populations, and the outcome says that the frontalis flap is actually better than LPSR in severe ptosis. That's because the LPS muscle in itself is quite weak. However, complications like eyelid deformity, entropion are actually quite common. There's an ongoing clinical trial between the frontalis flap and sling in Egypt, but the results are currently awaited. In our study, the MRD trend in both groups showed a significant improvement, and at 6 months, they were comparable. The frontalis flap had a more consistent outcome at 1 and 6 months. These are some of the findings, that the flap allows for a greater dynamicity. The scars are completely hidden, and this particular patient is able to use the frontalis flap by tugging the eyebrow under his turban. So this is a Punjabi effect called the turbinator, and he's able to utilize the dynamic nature of this flap. The limitations are the small sample size, and the both groups are not age matched. This technique is still new, it's a pilot study, and right now it's showing a comparable outcome, but we need a longer study to see its effect. Thank you.
So, what about the lid crease formation? Because
Since we had taken a levator plication bite, we were able to pass the skin, the combined frontalis muscle and the levator bite, and then back out of the skin to give the crease forming sutures.
but in the Sardarji, there was no lid. So have you repeated the procedure for the lid crease formation?
In flap, so far I have not had to repeat the procedure. There are 2 patients who are not a part of this study who underwent the frontalis flap, and they have an undercorrection, and for them I'm planning the sling. So this technique is still new. One major limitation which now the latest literature says is that in the frontalis flap, do an overcorrection of almost 2 millimeters above the limbus. I did not attempt that. I was afraid of risking a corneal exposure. But maybe in future cases with patient consent, I can probably try an overcorrection and see whether it's
So does the literature say that has there been any need of doing a sling after frontalis flap?
Ma'am, if it doesn't, because ptosis is a very visible cosmetic outcome.
Yeah.
So if the patient is not happy with the flap, I am not keen on revising the flap again. So I'd rather do a procedure which is more time tried and tested if my new
And is there any relation with the pre-op frontalis action of the patient and the results?
So there are, we have like the facial nerve stimulation test. We do have electrodes to test the frontalis muscle. I have not done that in my study so
Clinically, if you see the...
Yes, clinically we can identify if the frontalis recruitment is there. There is one point for this, that when they say that when the ptosis is corrected, in severe ptosis, once you have opened the eyelid and your MRD1 is above 1 millimeter now, the stimulus, the Herring's law stimulus of trying to use the frontalis goes down. So even after sling, Dr. Rashmi has previously described that even after doing a sling surgery, the patient refuses to use the frontalis anymore because the eye is open. So in that situation, how to retrain them to continue to use a dynamic flap, that is something under.
And how much length of frontalis do you pull out? Any demarcation for amount of ptosis?
I don't do the lateral incisions. I don't try and make a measured flap. I tug onto it until it comes comfortably onto the tarsus without causing any puckering on the skin. So the idea is to have a very good release in the supraorbicularis plane from subcutaneous while going above the eyebrow rim, and that's done with a blunt dissection. We can't go too medially because of the supratrochlear vessels over there, so we have to be careful, and easy traction so that it comes all the way to the tarsus without causing any puckering.
How would the brow height in both the cases?
So there was no lowering of the eyebrow. In fact, preoperatively, I didn't include in the assessment, but preoperatively the patient with severe ptosis had a higher brow height because of the constant recruitment.
So that is also one point in the symmetry part of it.
Definitely, in the future I will.
It needs lot of work, Abhi. We
is
all are seeing, I've also tried one, Abhi nahi maza aa raha, but it needs lot of work and we need some precision.
Surgical synergy is required for all these things.
But definitely that lid lag and sling ke jo scars hai, usse it gives very good relief to the patient. ठीक है. Next, I think one person is absent. So we have Dr. Aparna. She's going to speak on microbiology and antibiotic susceptibility pattern in CNLDO.
Very good morning to one and all. I am Dr. Aparna K.S. and my topic is microbiology and antibiotic susceptibility pattern in children with congenital
I think the slides are not running.
duct obstruction.
Yeah, दिख नहीं रही ना. Slides check कर दीजिए या run नहीं कर रही है. अब हो गया.
CNLDO is one of the major causes of epiphora in children. The impotency can lead to stagnation of tears in the lacrimal sac, predisposing to microbial growth. The microbiology profile and antibiotic sensitivity patterns keep changing with time, region, and preferred practices. So it is prudent to know the current sensitivity pattern to guide the empirical choice. In this background, aims and objectives of my study are to analyze the microbiological spectrum and antibiotic sensitivity in children with CNLDO and to determine appropriate antimicrobial agents. This is a prospective comparative study done in a tertiary eye care center in South India. We included 198 eyes of 170 children in the age group of 0 to 5 years with CNLDO. We included children during their first visit who are Droplas positive and excluded already treated cases of CNLDO. About 30 children in the same age group with other ocular complaints were included as control group. After detailed history taking and comprehensive clinical examination, microbial samples were collected by applying pressure over the sac area, and the discharge was sent for bacterial and fungal examination using culture-based techniques. Antibiotic susceptibility was tested using Kirby-Brewer disc diffusion method for the panel of drugs commonly used in our population. Statistical analysis was done. Coming to the results and discussion, out of 198 eyes, we had a slight male predominance compared to previous studies. 84% children had unilateral involvement with comparable involvement of right and left eye. In our study, no growth of organisms were observed in 5% of cases and 11% had a polymicrobial growth. And we had a slight gram-positive predominance, which is about 48%. And negative culture in our study is very low compared to previous studies, maybe because we excluded the previously treated cases. And the fact that not all discharges are infective must be kept in mind when a decision to start antibiotics arises. Distribution of gram-positive and negative isolates are highly variable in previous studies, and we had comparable result to Ushaki et al. Study done in 2006. Another recent South Indian study by Muthumalai et al. Showed a higher involvement of gram-positive organisms. In our study, the most common gram-positive isolates are Streptococcus pneumoniae followed by viridians, and most common negative organisms are Haemophilus followed by E. coli. And in Muthumalai et al. Study, Staphylococcus epidermidis was the most common isolate, maybe because of the frequent use of antibiotics changed the flora towards Staphylococcus epidermidis. Among the control group, 80% were either culture negative or had only mild growth of Staphylococcus epidermidis. Coming to the sensitivity pattern, for gram-positive organisms, it was highest for chloramphenicol followed by vancomycin, and for gram-negative organisms for aminoglycosides. But both group of organisms showed comparable and reasonably higher sensitivity for fluoroquinolones. And coming to the resistance pattern, for gram-positive organisms, it was highest for aminoglycosides including tobramycin, and for gram-negative organisms, it was highest for cephalosporins. Mann-Whitney U-test showed there is no significant difference in the sensitivity pattern of both group of organisms for ciprofloxacin, ofloxacin, and garifloxacin. Tobramycin is the most commonly prescribed antibiotic in pediatric age group, showed higher resistance, maybe because of the indiscriminate use. And in 2011, American Academy of Pediatrics approved topical fluoroquinolone for treatment of bacterial conjunctivitis, and they told it is well tolerated. So our study shows that both moxifloxacin and gatifloxacin have a better sensitivity profile compared to ofloxacin, but we would like to recommend the use of ofloxacin as the empirical drug of choice in CNLDO because of its reasonable efficacy and lower cost. So to conclude, presence of pathogenic microorganisms is common in CNLDO, and investigating the microbial profile is essential. Both gram-positive and gram-negative microorganisms were isolated in our study, and with a slight predominance of the gram-positive organisms. Streptococcus pneumoniae was the commonest organism isolated, and fluoroquinolones are the effective antibiotic for children with CNLDO because of its coverage of both group of organisms. And I don't have any financial disclosure. These are my references. Thank you.
Good presentation. Doctor, many times the patients come after using the antibiotics. In those cases, what you did?
Actually, in our study, we didn't take the previously treated cases. We excluded the previously treated cases, and we included only the first presentation only.
Means most of the time they have already used it.
Yeah, most of
they
the time.
Means you can always include them. You can take them, but there will be a gap.
Yeah, at least 4 weeks should be there, but for the purpose of study, I took like that. And this study is done in a rural area in South India.
Okay.
So most of the patients
Okay.
are coming after the age of 1 year, even though the presentation is early. In my study, most
Okay.
of the children came at the age of
Okay,
after
okay,
the
got
age
it.
of 1 year.
Any uncommon pathogens you came across?
No, madam. No, most of the pathogens were common organisms only we isolated, and
Okay.
no fungal isolates also.
Okay, thank you.
You recommend that we should stop advising TOBRA, which is we are doing so
Yes,
casually.
madam. That is why I started the study, because most of the prescriptions coming to me is they are using tobramycin, whatever it is, conjunctivitis, even for viral infection also. If it is pediatric population, most of the ophthalmologists are using tobramycin, and it is now it is showing resistance, maybe because of the indiscriminate use, and it has a intrinsic efficacy towards the gram negative spectra, and most of the pathogenic organisms are gram positive. So I strongly suggest this fluoroquinolones we have to start in children. That is approved by American Academy of Pediatrics also.
But in younger group, they say you should not prescribe fluoroquinolone.
Nowadays, they say aplastic anemia is not there due to that.
Newer guidelines suggest, like
Newer
even in
guidelines.
2011, AAP guidelines suggest that we can use, even for pediatric children after cataract surgery or any other surgeries, we are using moxifloxacin and all. So we can use it for this also. That will be better than using a drug which is not at all useful for a disease.
Thank you.
It will
Let's have few more studies before we change. Thank you.
Okay.
Good.
Thank you, ma'am.
Next we have Dr. Geeta.
Dr. Upali.
Okay, so Dr. Upali Tiwari. Good. Start.
Good morning, everyone. I am presenting a comparative study between electrocautery and conjunctivoplasty for the management of conjunctivocalysis. As we know, there's a proper functioning tear film is crucial for the ocular surface as it provides comfort and protects from environmental factors, and it smoothens the ocular surface for clear vision. So we have conjunctivocalysis, which is a chronic condition of the conjunctiva, which causes non-edematous conjunctival folds in inferior bulbar conjunctiva, both the eyes. It is one of the most frequent cause for ocular surface irritation and discomfort in the elderly population. For management of conjunctivocalysis, in surgical management, we have conjunctival excisional surgery and electrocautery. In radiofrequency, electrocautery is a minimal invasive procedure which is painless and very quick lasting procedure, lasts on 1 minute on average. There is a novel technique of conjunctivoplasty with fornical conjunctival suturing, which induces conjunctival adherence to the fornix and reduces the conjunctival folds. So the aim of this study was to compare electrocautery and conjunctivoplasty for the management of conjunctivocalysis, and one of the objectives was to evaluate the tear film meniscus using AIOCT before and after the procedure. It was a prospective interventional study done in a tertiary eye care center in South India with a sample size of 50 patients, 25 patients in both the groups. These are my inclusion and exclusion criteria. So consent was taken from all the patient, and for pre-operative and post-operative assessment, we did tear film breakup time and Schirmer's test, and with the help of Cirrus HTOCT 5000, we calculated tear film height, tear meniscus area, and cross-sectional area of conjunctivocalysis. This is the anterior segment AIOCT for conjunctivocalysis and normal tear meniscus showing. So for the procedure, for both the procedures, we did local infiltration of the conjunctiva with 2% lignocaine. For fornical conjunctival suturing, we did loose conjunctiva was draped into the fornix, and with the help of 60 Weichel suture, the conjunctiva was exteriorized at the corresponding area of the conjunctivocalysis. It can be taken laterally, centrally, and medially. For post-operative treatment, antibiotic and low-dose steroid, and if needed, oral analgesic were given. This is the procedure showing with the help of 60 Weichel suture. The conjunctiva near the fornix is exteriorized and suture knots were tying according to the conjunctivocalysis area. Then for electrocautery procedure, we did the area of the loose conjunctiva was retracted with the limbs forceps from the perilumbal area 4 to 5 mm from the limbus, and RF cautery in fulguration mode with the power of 1 millijoule was applied in 2 rows of burn. 1 to 2 seconds of cautery was enough to cause the blanching of conjunctiva, and the same post-operative treatment was suggested. These are the pre and post-op pictures of fornical conjunctival suturing and electrocautery. For the results, both the procedures showed a male preponderance, and mostly patients had grade 2 conjunctivocalysis according to Lipgoff grading. For results, the Schirmer's test did not show any significant difference between post-op periods, and there was no difference between both the groups. Also, tear film breakup time suggested significant post-op improvement, but the procedure difference between both procedures were not noted. As the same in tear film height also showed a significant improvement in both the procedure, but with the electrocautery group, it showed a statistically significant increase in tear film height in electrocautery group than fornix group. Tear film meniscus area also showed significant improvement in both the groups, but the results were comparable. Conjunctivocalysis area showed highly significant decrease in with both the procedures. And for discussion part, G et al. Conducted a study where patients who underwent high radiofrequency electrocautery for conjunctivocalysis correction showed a significant increase in tear film breakup time post-operatively. Similar to our study, Hara et al. Also found no significant change in Schirmer's tear test after surgery for calysis, indicating that maybe aqueous deficiency was not the primary cause of the symptom. Su et al. Demonstrated a significant improvement in tear film breakup time following high wave radiofrequency electrosurgery. In Kaglen et al. Reported a significant increase in tear film height after electrocautery and significant decrease in conjunctivocalysis, similar to our study. the conclusion, both the procedures are having similar effect on tear film characteristic, improving the tear film characteristic, and can be chosen upon the as the surgeon's preference. The conjunctival in initial period, the radiofrequency electrocautery showed better results and greater comfort to the patient. The main limitation of this study was functional questionnaire was not added, like ocular surface disease index, and longer term studies and larger sample size is necessary to see the long term outcome of both procedures. These are my references. Thank you.
Any particular reason for the male preponderance?
Ma'am, it was also done in rural and suburban population in Tamil Nadu. So mostly
More exposure to UV.
Yes, ma'am. According to
Which procedure was less time consuming?
ma'am, electrocautery was comparatively very faster, ma'am, because we just need to apply small burns, and that also for 1 seconds. So it very mild blanching we needed. So it was very fast, ma'am.
So your post-op results are almost comparable at all levels.
Yes, ma'am.
So
When we did post-operative period, tear film height was comparatively increased.
Otherwise, everything was comparable.
Yes, ma'am. Callosis area was decreased very, very nicely in both the procedures, ma'am.
Dr. Sangeeta.
Dr.
Thank you,
Sangeeta?
ma'am.
Good morning, everyone. My topic for presentation is non-surgical approach to orbital venolymphatic malformation. Lymphangiomas or venolymphatic malformations are multicystic localized malformations that involve the lymphatic and the vascular systems, mostly occurring in the head and the neck region. Currently, on classifying based on the size of the cyst, lymphangiomas are of 3 types: microcystic, macrocystic, and mixed. Now currently 4 categories of management options are available: observation, intralesional sclerosing injection, systemic medication, and surgery. Observation is done for smaller lesions. Situations like diminution of vision, mechanical ptosis, or cosmetic concern becomes indication for other modalities. Since these lesions are ill-defined, cursor is not working.
It is working. Too much sunlight you can't see, that is the thing.
There are risks and benefits to all 4 treatment types. Injection bleomycin can be a non-surgical option where directly lesion can be targeted. Also, very few studies are available where the treatment outcomes has been studied with bleomycin. So, purpose of the study is to assess the clinical presentation of orbital venolymphatic malformation patients and evaluate outcomes of injection bleomycin. So coming to the material methods, this was a retrospective interventional case series of 7 patients who was administered injection bleomycin. These are the pre-operative clinical photographs of the patients. So after general systemic and ocular examination, clinical presentation, location, and post-injection bleomycin outcomes were assessed. Outcome evaluation was done on the basis of improvement in the gross clinical appearance, and patient satisfaction was noted. Diagnosis of venolymphatic malformation is based on the clinical radiologic findings and supported by aspirate cytology. Here in image B, we can see T1 weighted contrast enhanced MRI scan of the patient showing significant proptosis of the left eye containing multiple cysts with fluid levels. Now in this image, here we can see multisepted large cystic lesion inferiormedially with heterogeneous contents. In this case, image B is showing proptosis of the left eye with fluid level in the retrobulbar space, which is pathognomonic. Now in this image, we can see proptosis of the left eye containing multiple cysts, again with fluid level, with thin enhancing cyst wall in the retrobulbar space. Thus, based on the clinico-radiologic finding, patients were planned cyst aspiration with injection bleomycin. Reconstituted bleomycin is made by adding sterile water to 2% lignocaine in the ratio of 1:1, and dose of 0.5 international units per kg body weight per sitting was given. 20% of the aspirate amount was administered, and injections were repeated every 4 weekly whenever required. Bleomycin acts by irritating the endothelial lining, causing inflammation and involution of the lesion. Here is a small video demonstrating the procedure. coming to the results, out of the total sample, 71% were females, age range from 2.5 years to 20 years. Macrocystic is the most common variant and orbitopalpebral is the most common location, and almost all cases presented with lid swelling and proptosis. 2 patients presented with ocular motility restriction. And to sum up the treatment, 2 sittings of 8 international units of bleomycin was required, resulting in 82% reduction in the original cyst volume with 3.3 millimeters mean reduction in the proptosis with nil systemic and minimal local side effects, including swelling and subconjunctival hemorrhage, and no recurrence at 6 months follow-up. Now coming to this discussion, similar study was done at LVPI where the lid swelling and proptosis were common presenting features, though common variant was microcystic. 3 sessions of intralesional bleomycin were given and outcomes were similar to our study. Similarly, Shankar Nethralaya, Hyderabad reported 60% reduction in the mean volume of the lesion following 2 sessions. These are the pre-injection, post-injection photographs of the patient. Now coming to the conclusion, orbital venolymphatic malformation mostly presents with lid swelling and proptosis. Injection bleomycin is easy to inject and avoids post-surgical morbidity. A mean of 2 sessions are required for significant reduction of the lesion. There is quick post-op recovery with minimal systemic and local side effects with no recurrence. My take-home message is all variants of venolymphatic malformation can be successfully treated with intralesional bleomycin with nil systemic and minimal local side effects with near total resolution of the lesions after 2 sittings. Thank you.
Thank you. All variants can be successfully treated?
Yes, ma'am.
Because there are some of the posterior variants.
Yes, ma'am.
You can successfully treat it.
Success in the terms we can achieve maximum reduction, more than 80% reduction in the clinical as well as radiological appearance. We can see.
What imaging modality you took?
Ma'am, MRI.
No, I'm telling about during the procedure, what imaging modality?
Actually, it was done keeping the MRI, considering the MRI features,
in
but
none of the cases you took.
It was not done.
Not done. So you cannot go very interior limits. It's an intraconal or the retroorbital means it is a very deep seated. You cannot do that.
Yes,
so in those cases, you may have to do it under imaging guided, USG guided or CT guided.
Yes,
and in some of the cases, I don't know, but some of the cases you may have to do surgery also later anteriorly because you can do combined. You can combine it. The more anteriorly located things that you can do surgery and the.
Yes, ma'am. The modality of treatment we use depends on the superficialness of the lesion.
Okay.
And
Good.
as well as we can combine surgery along with sclerosant agent.
Yes. Thank you.
Thank you.
Next speaker, Dr. Pratibha. She's going to speak on tier biomarkers in thyroid eye disease. Probably the first.
Good morning, dear respected judges and my dear colleagues. I am Dr. Pratibha Devi Nivian and I am here today to talk about tier biomarkers in thyroid eye disease, the first Indian study. So thyroid eye disease, as we all know, is an autoimmune disorder. The understanding about the pathogenesis is evolving these days. It's an autoimmune disease in which there is production of antibodies against self-antigens, which due to the inflammatory derangement, it causes either fat proliferation or a fibrotic change. So we know the thyroid eye disease has varied presentation from a simple mild eyelid retraction to a very severe, dreadful, visually debilitating disease with exposure keratopathy and dysthyroid optic neuropathy. So what we do, we today treat the patient based on the clinical activity scoring or the visa scoring. We treat them either with steroids, immunosuppressants, radiotherapy. Few targeted therapies are available in the West, few are available here. But most of them in the audience and the judges would agree that the treatment of an active, full-blown thyroid eye disease is very challenging because we treat the patient after the disease is well established. So what could be ideal is to identify the patients who will develop the disease and treat them before the onset of the disease. So how can we find who will succumb to the disease is to look for biomarkers. It can be obtained from various body tissues. But tears is an ideal source because it's in direct contact with the eye, the lacrimal glands are also affected, and it is very easy to procure tears. In this angle, we did a literature search and we found quite a lot of interesting work done on tear biomarkers in thyroid eye disease. And this one particular journal from the biomolecules is a meta-analysis where the authors had compiled the work, and they have most of the authors have found few of the inflammatory cytokines to be increased in thyroid eye disease. With this background, and since we did not have any Indian study, we aimed to look for the significant markers in tears and thyroid eye disease. So it was a pilot study done prospectively after ethics clearance. We diagnosed thyroid eye disease by Gorman and Bratley's criteria, and we graded the activity using the VISA scoring and graded the severity using the UGOGO guidelines. We procured tear samples from 2 tertiary centers, and we used the Shermer strip to procure the sample, and we stored in minus 90-degree refrigerator, and the samples were analyzed in a lab in another tertiary care center. We collected the samples from healthy controls, patients with thyroid eye disease, patients with thyroid disorder but no eye disease. We excluded the patients with other systemic and ocular disorders and not willing for the study. We performed multiplex ELISA in the tear samples, and our panel had included the inflammatory markers which were established, proven to be affected in thyroid eye disease. So we had 19 patients with thyroid eye disease, 11 were patients with thyroid eye disorder but without an eye disease, and 13 healthy controls. Among the patients with thyroid eye disease, we had 11 active patients and 8 inactive patients. This was the result of our study. We found that the inflammatory cytokines were elevated in thyroid eye disease. All the inflammatory cytokines were elevated, but interleukin 6 and 10 were statistically significantly elevated. And we also noticed that IOP was also significantly elevated in active eye disease, and IOP was directly related to dysthyroid optic neuropathy. Interestingly, we noticed that tocilizumab, which is an interleukin 6 antagonist, is being given as a treatment for active thyroid eye disease, and randomized control trials have been done for that. And we did notice that there are a lot of targeted therapies for thyroid eye disease, and they have been proven to be successfully treated. So in future, biomarker detection would give a clue to find who would succumb to the disease, and the potential markers and treatment with the specific antagonist could probably avoid a high-dose steroid treatment or recurrence. To conclude, tear biomarkers can be a promising clue to diagnose patients at risk of developing sight-threatening complication. These are my acknowledgements. Thank you.
Thank you.
Very good presentation.
Dr. Anisha is here.
Good study.
Thank you.
Dr. Maya.
Anisha is not there.
You are Dr. Anisha? After her. नहीं it's okay.
करो डॉक्टर माया। अच्छा, डॉक्टर अनीशा आप आ जाओ। इसकी सेकंड प्रेजेंटेशन है क्या? इसने अभी एक और भी करी है ना? क्या नहीं? कोई और स्टेशन?
Good morning everyone. I shall be talking about a case of an adverse reaction of lignocaine, not because it's something very extraordinary, but this sort of adverse reaction can be really very troublesome for not only the patients but for the surgeons as well. To begin with, few fundamentals of lignocaine. It's an amino-acyl amide. On injection, it acts on the fast voltage gated sodium channels, alters the signal propagation, therefore the postsynaptic neurons do not depolarize, and therefore the action potential is not transmitted. To begin with our case, we have a 27-year-old male who presented with watering from both eyes, and on examination was found to have bilateral punctal stenosis. So we plan to do a bilateral punctal snip, and the patient underwent the procedure. Under 2% percutaneous lignocaine, 1.5 ml at each side was injected to block the infratrochlear and the infraorbital nerve. He was examined at day 1 and 7, and the patient was doing all right. But at 1 month, he came to us with complaints of blackish discoloration as a black arrows point at the sites of the injection. And as we can see, there was localized hyperpigmentation which was mildly inflamed with very well defined margins. So we prescribed the patient on topical steroid ointment and topical kojic acid ointment both once daily, and called him after a month. So now the patient has come after 1 month, and we can see the red arrows point towards Hyperpigmentation with little diffuse margin now, the inflammation subsided and the intensity of hyperpigmentation has remained the same. So we asked him to continue kojic acid ointment for 1 month, stop the steroid and called him after 1 month. Patient was lost to follow-up, came to us after 4 months and now we can see the pigmentation has become really diffuse to the extent that the entire periocular skin now looks black. We referred to a dermatologist and the patient later benefited somewhat with chemical peel and laser ablative resurfacing. A quick glance at the literature, not many available, but Dr. Savita Yadav et al. Reported a case of this sort of streaky hypopigmentation in a patient after periangle wart excision under lignocaine anesthesia. I have cited 2 other articles where there is evidence of petechial and purpuric eruption after application of EMLA and prilocaine cream. So what is a drug-induced hyperpigmentation? Any pigmentation temporarily associated with a drug use where all other potential causes have been ruled out. The etiopathogenesis suggests deposition of melanin under the dermal macrophages, which can be direct trigger from the drug or can be due to some non-specific inflammation. And there are also evidences which suggest that the drug itself can get deposited under the dermal macrophages, causing this sort of effect. It has been seen to get worsened by exposure to UV and sun rays, and there are also evidences which suggest deposition of toxic chemicals released by the drug in the blood vessels and also iron in the blood vessels, which cause lysis of the blood vessels, causing pigmentary disturbance. So coming to our case, the pigmentation was initially very localized, which later became diffuse. So this kind of indicates the spread of the drug through the facial lymphatics, which might have some unrecognized interaction on the ion channels of the melanocyte cells, causing this sort of hyperpigmentation. So the take-home message from this case is whenever we are dealing with such sort of adverse reaction of drug, it's advisable to deal little aggressively and to sought for other specialty intervention at the earliest, like in this case a dermatologist intervention. And why is this case worth a discussion? Because definitely because of the rarity of this sort of adverse reaction, and second, lignocaine is rampantly used in various sort of oculofacial as well as aesthetic procedures. So this sort of adverse reaction can be really very aesthetically unpleasing. So it will be really very interesting to study the action of lignocaine on melanocyte cells in vitro models as well as in animal models, and also to see whether there is any genetic predisposition that might lead to the pigmentary disturbances following lignocaine. These are my preferences. Thank you.
Any relation to the dose and this side?
Ma'am, as we saw the literature and also in our case, we don't, all of these were very minor surgical procedures or aesthetic procedures, so the dose was really less. So in our case, like it's 1.5 ml at each side of the nerve block on both the sides. So I don't think it's related to any higher dose.
Okay.
Okay, very good morning. I'll be presenting the clinical microbiological profile and outcomes in 14 cases of periorbital necrotizing fasciitis. No financial disclosures to make. So necrotizing fasciitis is basically a threatening infection of subcutaneous tissue that mainly affects the limbs or abdominal wall. Occurring of NF at periorbital region is very rare, and the incidence are 0.24 cases per million per annum in a UK study. So here we present 14 patients of PONF and describe their clinical microbiological profile. It was a retrospective review of 10 years at the tertiary eye care centers, and the diagnosis was established on the basis of clinical presentation of rapid spread of cellulitis associated with subcutaneous necrosis. 14 patients were identified, and mean age of presentation was 17 years with a range of 1 to 64 years, and there was a male predominance. 4 of the cases were having a history of preceding injury, and a preceding infection was seen in 5 cases, which was there as a sinusitis, otitis externa, and erysipelas. So this was a young patient, 2-year-old, with skin infection, that is erysipelas, followed with PONF. This was a patient of periauricular infection associated with PONF, and this was a patient of PONF with insect bite. The clinical presentation, most common symptom was periorbital pain, and the most common presenting sign was tense cyanotic eyelid edema. The area of inflammation involved periocular area only in 9 cases, facial involvement was there in 4 cases, and orbital involvement was there in 1 case. We also correlated the extent of involvement with LRI-NEC, that is a laboratory risk indicator of necrotizing fasciitis score, and the mean score was 1.12, and there was a significant correlation with the extent of involvement, means higher score was calculated with facial and orbital presentation. There was a systemic association seen in 6 of the cases, and immunosuppressing conditions like hematological malignancies, long-standing diabetes, and alcoholic liver disease were there in these cases. All the cases received intravenous antibiotics and underwent surgical debridement, which was in the range of 1 to 4 times. IV immunoglobulin were given in 2 cases, and orbital exenteration was done in 1 case. Reconstructive surgery with full thickness skin graft was needed in 12 cases. In the microbiological profile, the most common isolated bacteria was group A Haemolyticus streptococcus. This was a patient with chronic alcoholic liver disease with right-sided PONF with facial involvement. He underwent debridement, and you can see the extent of involvement into the temporal fossa. However, the orbital involvement was not there. There was a state of systemic shock, and he was given intravenous immunoglobulin. And after repeated debridement and skin grafting and reconstructive surgery, he achieved good cosmesis. However, the vision was lost. This was a case of chronic kidney disease with diabetes, and bilateral PONF was there. She also received IV immunoglobulin and underwent full thickness graft. This was a patient of orbital involvement with myelodysplasia. He succumbed to the multisystem, multi-organ failure. This was a patient following poorly controlled diabetes, following minor trauma, and following insect bite. There were many pediatric cases in our series following sinusitis and insect bite. All underwent surgical debridement. They all underwent skin grafting for the leg of thalmos, and all were doing well with minimal leg of thalmos residually. So, as per the available literature, PONF is essentially a disease of adults with an average age of presentation being reported as 50 years. And in our series, 8 of the cases were below 5 years of age. We suggest to have a high index of suspicion in children presenting as orbital cellulitis. And we found that mortality rate in our study was 7%, and it was comparable with the available literature and the larger reviews which are published, and support that PONF has a relatively better outcomes and lower mortality than NF elsewhere. So this series highlights that PONF can be well managed with early recognition of disease and prompt surgical debridement of necrotic tissue and aggressive antimicrobial therapy. And to the best of our knowledge, it is the largest series of PONF from the Asia Pacific region till date. These are my references. Thank you very much.
What antibiotic we used?
Ma'am, we use broad spectrum vancomycin with ceftriaxone and metronidazole. In all patients, there were 2 patients in which linezolid was used in place of vancomycin.
Clindamycin actually is suggested for this.
Yes.
Clindamycin, that is the
actually,
best.
we are in a government setup where metrozil is available free of cost. So that's
metrozil will not work for necrotizing fasciitis.
Patience is the key factor for treating necrotizing fasciitis.
But we, in our series, we had a good results with
before you reach the stage of skin grafting, before that also, I think it takes a number of sessions of repeated debridement and taking care. That is very important.
Around 3 to 4 times debrided in maximum of cases.
More than that, so that is very important. Thank you. Nice series. And with this, we finish this session. We can have a group photograph with all the presenters, if we wish, and then we conclude. I think everybody has some session at 9:45, so it's better we conclude.